Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development for Holy Cross Health. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situation in this public forum. For those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health. And we at Holy Cross are happy to be your partner in your health journey. Today's topic is breast cancer and advances in radiation therapy. According to the CDC, breast cancer is far and away the most frequent cause of new cancer cases for women, with over 264,000 new cases in the US in the most recent year the data is available. And breast cancer is the second leading cause of death among all cancers affecting women, behind only lung cancer. There have been numerous advances in the treatment of breast cancer in recent years, and we're here to learn about them from the experts at Holy Cross. We're joined today by Dr. Sheila Moden and Dr. Erica Ristjian. Dr. Moden is a radiation oncologist and the medical director of the Holy Cross Radiation Treatment Center, which under her leadership has been certified by the American College of Radiology for its high standards and quality. Dr. Moden has practiced at Holy Cross for 24 years. She has a strong interest and expertise in breast and gynecologic cancers, participating in clinical trials and tumor boards, in addition, of course, to patient care. Dr. Ristjian is a breast surgeon and a general surgeon that serves as the medical director for the breast center at Holy Cross Hospital. He was born and raised in the Washington area and has practiced surgery at Holy Cross for 38 years and was responsible for organizing the first breast cancer treatment center in Montgomery County to be certified by the American College of Surgeons right here at Holy Cross over 10 years ago. So, Dr. Ristjian, I'd like to start our questions today with you. We'd like to just do a bit of an overview of breast cancer in general at first, and we'll go from there. So could you just tell us what are some of the signs and symptoms of breast cancer?
So the biggest problem with breast cancer is that there are very few signs and symptoms of it. Some women will develop breast masses and bring them to the attention of their physician, but the vast majority of those breast masses turn out to be benign. That is why it's so difficult to diagnose breast cancer and why screening was begun many, many, many years ago. What the goal of doing, the goal is to identify cancer at its earliest stage so that it can be treated effectively. And that's the purpose of screening.
And so you mentioned screening, and of course, that's a big part of the whole process of looking for and treating breast cancer. Tell us about screening. What are some of the current recommended guidelines when it comes to screening?
So there's been a lot of confusion recently about what is appropriate screening. So to move back a little bit, when we first started doing screening, there were studies to determine how effective screening was in saving lives. And the data is very robust and it is very well documented that screening, women who undergo screening on a regular basis have a 40% decrease in their mortality from breast cancer if they undergo screening, as opposed to women of the same age who do not undergo screening. So first off, screening is very important. The government got into this several years ago and decided they were going to make recommendations on how they felt people should be screened. The bottom line is that the current recommendations are that women over the age of 40, no matter what their risk factors, should undergo screening, a yearly screening mammogram and a yearly physical examination by a physician. This has been indisputably shown to decrease the rate of mortality in women who develop breast cancer.
And so if a woman has this screening done and an area of concern is identified, can you tell us a bit about what the process of diagnosis would look like from that point forward?
So nowadays, most women get their screening through their primary care physician or their gynecologist. And those doctors oftentimes will get an abnormal mammogram report with the suggestion that the patient undergo a core biopsy. When I was a resident, we did our biopsies all using an open technique where we actually put patients to sleep, made an incision in the breast, and removed breast tissue. This was not only frightening for patients, but also quite deforming. So we now have switched to where we recommend that all patients who have an abnormality that is concerning for cancer undergo a percutaneous core biopsy rather than an open biopsy. We sample tissue using core needles that remove enough tissue to be able to identify the process and determine if further treatment needs to be done. The abnormalities that are seen on mammography, even when they are called suspicious, only 30% of them turn out to be malignant. Far and away, the vast majority of these things that are seen on imaging are benign. So in doing core biopsies, we save patients unnecessary surgical procedures, but more importantly, can plan to do appropriate surgical procedures.
And is it possible for breast cancer to spread to other parts of the body?
So Amy, the definition of a cancer is that it is a growth that starts in one place and then spreads to other portions of the body. What we would like to do is make the diagnosis of a cancer before it's had the chance to spread. But we have to keep in mind when we look at treating patients with cancer that even though all of our studies and all of the imaging tests that we have done show no evidence of spread, we treat patients as if there is the potential for microscopic spread. So when we look at talking about treating breast cancer patients, we talk about treating the breast itself in order to remove the cancer. We talk about sampling lymph nodes to see if there's any evidence that tumor has spread to the lymph nodes, which is a biologic marker of aggressiveness. And then we give the patient some form of systemic therapy or some form of medication to treat any cells that may have left the breast and gone elsewhere.
And briefly, are there risk factors for breast cancer that patients should know about?
Yes, there are. And nowadays, rather than just focusing on treating breast cancers, we now have things that we can do to limit risk for breast cancer. So when we talk about risk, there are two basic categories of risk. One are non-modifiable risk factors, and the other are modifiable risk factors. The non-modifiable risk factors are basically hormonal type factors and family history. So patients who have an early onset of menses, have a late menopause, bear children after age 35, those women all have an slightly increased risk to develop breast cancer. But those are things that can't be changed. We also know that there are certain things that put you at a higher risk to develop breast cancer. And the biggest one is obesity. With women with a BMI over 31, which is BMI is a computation of height and weight. If their BMI is over 41, that increases their risk for breast cancer by 30%. If you smoke tobacco or drink excess alcohol, these also increase risk for breast cancer by about 10%. And interestingly enough, it's not only weight, but lack of activity that can increase the risk of breast cancer. We're all now couch potatoes, sitting at home, looking at our phones, not going outside and getting fresh air. If you sit for 3 hours in front of your computer, that's not a good thing to do. That increases your risk for breast cancer. So there are modifiable risks that we can talk about. One other thing that's very important is the use of exogenous hormones. So women after menopause don't feel so good. And the use of exogenous hormones makes them feel better. But certain combinations of exogenous hormones markedly increase the risk of breast cancer. So they have to be used judiciously in patients who are at high risk. Even the birth control pill, although there's not a huge risk, increases the risk for breast cancer by about 2%. But women who are in the age where they're going to be taking the birth control, don't have a tremendously high risk for breast cancer. So that 2% risk is really negated by their youth. The last thing that we now put on the table to help patients at high risk is there are medications that we can give that cut the risk in half. So these are all very important things to consider and something that I talk to all of my patients about when they come to see me.
Dr. Rishton, thank you for that whirlwind tour of breast cancer and what it is. So Dr. Moden, I'm going to turn to you now and talk about radiation therapy, your specialty. Could you, to start, just briefly explain to us what is radiation therapy and how do you use it to help treat cancer patients?
Sure. So radiation treatment really involves the delivery of high doses of X-rays to kill cancer cells and to shrink tumors. And depending on the type of cancer and where the tumor is, different radiation treatment techniques and different radiation approaches are used.
And so let's dive into that a little bit. What are some of the different kinds of radiation therapy that we have available in general, and what is it that we have available at Holy Cross?
So, when we consider what kind of treatment to use, what kind of radiation treatment to use for patients, we rely on, national guidelines and evidence-based approaches to determine what treatment approach and what treatment technique would be most effective for an individual patient. So some patients may get a standard radiation treatment, which is typically given once a day for several weeks. We can also use something called SBRT or SRS, which stands for stereotactic body radiation treatment or stereotactic radiosurgery, which are highly precise treatments to deliver tumoricidal doses to a tumor. And we can also use radioactive seeds to deliver radiation directly to a tumor. Such as in prostate cancer or gynecologic tumors.
So we're obviously here to talk about breast cancer today. You mentioned a couple of other different types of tumors that we can treat. What are all of the different types of cancers that we're able to treat using radiation?
So in general, since radiation is directed to a particular site, it's usually used in cases, as Dr. Rishton alluded to, it's used in cases where the tumor has not spread. So at Holy Cross Hospital, we use radiation treatment. The types of treatment, tumors that we treat include obviously breast, but prostate, gynecologic tumors, head and neck tumors, brain, lung, pretty much any of the solid tumors, radiation is used. But having said that, though, radiation treatment is also very important in, controlling pain, stopping bleeding, alleviating obstruction of critical organs by a tumor. So it's used for in multiple situations, and mostly with cancers.
Can you explain for patients just what the process would be like? Let's say a breast cancer patient. What would the process be like for her to actually go through the steps required to receive radiation therapy?
So typically, patients are referred to us by medical oncologists or surgeons like Dr. Rishton once a diagnosis and staging has been established. Then a patient would come in for a consultation, and at that time we would evaluate the pathology, all the imaging studies, and also we would integrate that with our clinical evaluation of the patient when we see them and examine them. And once you've determined that this is a situation where radiation can be helpful, a patient would have a planning session so we can plan the treatment. And we use a planning CAT scan, which gives highly detailed imaging of the area that we need to treat. And this is where patients get marks and measurements so that we can have accurate delivery of treatment. Once the planning CAT scan is done, I and the physics team actually plan the treatment. So we decide the kind of radiation we're going to use and the treatment technique, after which patients then come back and start having their treatment. And this would be the same for breast patients as well as for pretty much any other area that we treat.
And one thing patients often are concerned about with radiation is side effects. What are some of the things that we're able to do to minimize the side effects that someone might experience from these treatments?
So when we plan a patient, when we're doing the planning session, we use a number of different sophisticated devices positioning devices. We use different, and when we plan the treatment, we use different techniques. And so all of the purpose of that is to try to obviously get accurate treatment, but also to try to minimize scatter dose and also the side effects. And so all of the effort that we put in the planning session and in the behind the scenes planning are actually very helpful in trying to minimize the side effects. And so we use these positioning devices and different techniques in order to do that. In fact, in many sites, we use something called IMRT, which is a highly complex plan, which targets the tumor that needs to be treated and minimizes dose to surrounding structures. So by using these kinds of techniques, we minimize the side effects.
So, Dr. Rishton, I want to turn back to you now, and let's talk about breast cancer again specifically, now that we've gotten a good overview of what radiation is in general. Obviously, there's different ways to treat cancer, different ways to treat breast cancer. We've heard mention of several of them already: radiation, chemo, surgery, others. Can you tell us how you determine that surgery is the right way to proceed for a breast cancer patient?
So at Holy Cross, we are blessed to have a certified breast cancer treatment center. So all of our patients are presented at tumor board prior to making any decisions about what we're going to do to treat them. As good as I am at doing surgery, I'm really bad at undoing surgery. So I would like to involve all of the modalities of treatment prior to going into the operating room. So each and every one of the patients that has been diagnosed with breast cancer since 2011, who has come through our breast center, has been presented at tumor board. We discuss in an open forum without identifying the patient, the disease process. We go over their x-rays as a group. We look at their pathology slides as a group. We then discuss the pathology, the pathologic staging, what additional imaging should be done. We discuss whether or not there should be genetic testing done. We discuss whether or not we want to proceed with chemotherapy before we do surgery. There are many patients now that present with fairly early breast cancers who actually do much better if they're treated with chemotherapy before they go to the operating room. So I think that the tumor board is the cornerstone of the way we treat our patients at Holy Cross. We want to involve everybody from the beginning, our breast cancer team, to give all of our patients the best possible care.
And if a patient does, go through the tumor board process and it's determined that surgery is perhaps in concert with another modality or perhaps on its own, the correct way to proceed, I'm sorry, I'm going to ask you to summarize much of your practice in a couple minutes here, but what are some of the different types of procedures that you can perform to treat breast cancer?
So the vast majority of our patients nowadays that are treated are able to preserve their breasts, which is very important. Because of screening, most of our patients present with early breast cancers. And those patients, we would present them at tumor board and generally do a lumpectomy, and with Dr. Moden's help, preserve their breast, and they would most of the time get postoperative radiation therapy to make sure that the tumor does not recur in the breast. At the time that we do the lumpectomy, we also sample 1 or 2 lymph nodes to determine if there's any evidence that the tumor has spread to the lymph nodes, to aid our medical oncologists in deciding what types of systemic therapy they should get as well. So it's a 3-pronged approach: surgery, radiation, surgery and radiation, I'm sorry, sampling of lymph nodes, and chemotherapy. We do lumpectomies. We also do mastectomy in patients who present with higher stage tumors, larger tumors, where there's not enough normal breast that we can preserve it, or if doing breast preservation would not help them in their overall survival.
And what about reconstruction? Is that something that's available at Holy Cross?
So we are blessed to have an outstanding plastic surgeon who is very talented. We do immediate reconstruction, beginning of immediate reconstruction at the time of most mastectomies. where a submuscular expander would be placed on the chest wall, which would be slowly inflated to try to equal the size of the native breast that remains. He also does autologous flap reconstructions and has probably the best overall success rate in doing that, taking a portion of the abdominal wall and creating a breast out of it. A very complex procedure with amazing results. He also is able to do what's called reduction for symmetry. If a woman happens to have a very large breast that requires treatment and we have to remove that breast, it would be very difficult to do a reconstructive procedure on the side that the breast was removed and equal the same size on the other side. So Dr. Alatar very frequently does reduction on the other side so that the woman looks symmetrical and whole after he has completed his reconstruction.
So, Dr. Moden, I want to turn back to you and talk a little bit more about radiation specifically. We've talked a little bit about this, but I think it's helpful to clarify it and explore it a little bit further. Let's stick with breast cancer. How would a breast cancer patient typically find her way to you as a radiation oncologist? Can you tell us about the journey that that patient goes through before they even get to the treatment stage?
Sure. So, patients are presented at tumor board, and usually either after their surgery or after chemotherapy, if they have that, patients will be referred by a medical oncologist or by a surgeon to come in for a consultation. And that's the time in which we not only go over whether it's appropriate to do radiation, we'll have a good idea about what kind of radiation, but we're very focused on understanding what the patient, what's the patient's needs, what is it that their expectations. We try to be very clear and complete about when we talk about side effects and how patients can deal with it and how we can deal with it, and help them through it. So, and then, they are scheduled for the planning session, and that's actually not only where we get imaging, and we have the virtual patient at that point to be able to plan our treatments very accurately, but that's also where patients get their marks. They get temporary marks initially, which are eventually replaced with little tattoos, which are permanent, but they're very small. They really just look like moles. But they're extremely important because they are used for accurate delivery of treatment. And so that sometimes takes a little bit of convincing sometimes for some patients, but most patients understand the need for that, and they're very much invested in having accurate and safe treatment. So then, of course, as I said, once the planning session is done, it may take a week and a half, somewhere between 1 to 2 weeks, for the patient to come back to start their treatment once the plan has been done. And very often we'll have a patient come in to do sort of like a test run. So we will have them get on the table. They will have the images taken of the area that we need to treat, and we'll make sure that it's still accurate. Sometimes patients have some swelling, when they first come and they have their planning session, all of a sudden that subsides. And of course, we need to replan because anatomy is everything to us and being accurate is everything to us. And then they start on their treatment, and they're seen at least once a week by a physician, and just so that we can check in with them, see if they have any side effects, if they have any questions, just help them through, emotionally and obviously medically. But we also have nurses, and we have very experienced therapists who are also resources for patients.
It's a really important point to consider that it's an entire care team that is working for patients. It's never just one physician working in isolation. It's many physicians and many people. And Dr. Moden, I know that you've been working on something that's been taking a lot of time and energy It's the Holy Cross Health Cancer Center. Could you tell us a bit about the new cancer center and how it's
Sure.
going to benefit patients in our community?
Oh, absolutely. We're very excited that we're going to be moving very shortly to a new radiation treatment center, new cancer center. It's maybe less than a mile away, but it's much larger, brighter. It's above ground, so there'll be lots of windows. For patients, there'll be better access and better parking, which of course is a big issue. But I think most importantly, it's been specifically designed to promote a healing environment of care. And the patient experience has been put at the forefront. So I think this will be extremely important for patients. The other way in which it's going to benefit patients is that we're getting 2 new linear accelerators, 2 new treatment machines. We're getting a new CT planner, and we're getting some new planning systems, and all of them will be integrated with Holy Cross Hospital's medical records. And so this should improve a patient's experience and patient's care, because it'll provide seamless transition between different specialties and different disciplines.
And can you tell us some of the advanced technology that will be incorporated into the cancer center as it pertains to radiation?
Sure. So we have, as I said, we're going to have 2 new machines and very, very complex treatment planning systems, which will enable us to deliver state-of-the-art academic level quality treatment to our patients, but in a community setting. In fact, one treatment machine is called the Edge, will be the only one of its kind in this region. And it has very advanced technology and capabilities to precisely treat tumors. And very interestingly, it also can treat multiple tumors in very vulnerable areas, like the brain, with extreme precision.
Yeah, this is something that there's been a lot of work, a lot of energy from people all around Holy Cross, and it's something that we're very excited about. So it's amazing to see it finally come to fruition here in the near future.
Yes, we in the department are all looking forward to it.
How can patients schedule an appointment for radiation?
Well, they can call our department at 301-681-4422. That's a general department number, but they can also go to the Holy Cross Hospital website to get contact information. And we have, people who, at our front desk, we have fluent Spanish speakers, and that also is helpful. And we will get people right in.
All right, thank you, Dr. Moden. As we look to wrap up here in the next few minutes, Dr. Rishton, want to turn to you to talk about the breast program at large. You were as I mentioned up front, the real driving force behind Holy Cross Hospital becoming accredited as a comprehensive breast center. Can you tell us about what that means and why it's important for patients to seek out care at an accredited center?
Better care. It's very easy. This was a very easy decision. I've been at Holy Cross for a long time. I've been treating breast cancer patients for over 30 years. Holy Cross asked me to try to organize the services. It became very clear that in organizing the services, we needed to A, treat our patients better, and B, do it in a organized fashion. About the time they asked me to organize breast services, NAPBC came into being, which is a American College of Surgeons certified organization that gives accreditation to breast centers. I knew from my long time being at Holy Cross that we had all of the components available to become a certified center, so we went about the task of doing that. So it's a very easy process. Patient comes in to see me. We start talking about breast cancer, and they're frightened. And in the course of the discussion, I say, well, would you like to have 7 or 8 opinions about your breast cancer? How about we talk about your breast cancer? We get your slides. We look at them with our pathologist. We bring your x-rays, look at those x-rays, and then we discuss using the template of national guidelines what would be the best thing for you, what would be your best care, how we would treat your breast, how we would sample the axillary lymph nodes, how we would organize the data so that we would give you the best possible systemic therapy. So that was how this came about. It's nothing difficult. It's nothing magical. It's just better care.
Well, thank you so much, Dr. Moden and Dr. Ristchen, for all of the insights that you'd offered here today. We're about out of time. Thank you, everyone, for tuning in today. If we didn't get to your question, you can find additional information through Holy Cross Health's blog, or we can connect with you one-on-one via the phone or on our website. You can visit our website to learn more about breast cancer care and the Holy Cross Radiation Treatment Center at holycrosshealth.org/location/Holy Cross Radiation Treatment Center, or at holycrosshealth.org/breast. Dr. Moden, Dr. Ristchen, thank you again. And thank you on Facebook for joining us at Facebook Live with Holy Cross Health. We hope to see you again soon.
Thank you.
Thank you. Good night.
Good night.